Good morning, dear friends and delegates and respected faculty. We welcome you to the next session of Pediatric Dermatology course. Today, Dr. Rohit Batra, Senior Dermatologist from Sir Gangaram Hospital in Delhi, he'll be speaking about the infantile hemangiomas. Infantile hemangiomas can be either very benign, which disappear spontaneously without doing anything, but they can be associated with serious abnormalities also. I welcome Dr. Rohit Batra sir and request him to please start sharing his screen.
Thank you, Dr. Ajay Gupta, sir. And it's a proud privilege to be here today in this IEP's pediatric dermatology course. My screen is visible? It's full screen?
Yes, sir. It's visible.
Yeah. So welcome all the delegates on this chilly Sunday morning, early morning rather, I will say, when it comes to Sunday. And in next 30 minutes, we'll be talking about infantile hemangioma. I am Dr. Rohit Batra, consultant dermatologist at Sir Gangaram Hospital, New Delhi. And we see a lot of patients of hemangiomas. Most of them, as Dr. Ajay pointed out, are benign and they don't require any treatment and they just go on their own also. But at times you require uh, some help from your dermatologist friend, or you have to treat the patient yourself. So, talking about hemangiomas, infantile hemangiomas are benign proliferations of endothelial tissue and their supporting tissues. They represent the most common tumors of infancy. They are characterized by significant growth during the first several months of life, followed by slow spontaneous involution over ensuing years. So when we talk about the classification for vascular abnormalities, we see there are vascular tumors and there are vascular malformations. Talking about the vascular tumors, you have the benign and locally aggressive or malignant. And infantile hemangiomas, as we discussed, are the most common benign vascular tumors, followed by congenital hemangioma, tufted hemangioma, spindle cell hemangioma, epithelioid hemangioma, while locally aggressive are the ones that are Kaposiform hemangioendothelioma, retiform hemangioendothelioma, and malignant are angiosarcoma and epithelioid hemangioendothelioma. So 1 to 2.5% of newborns with an incidence of 4 to 5% in the first year of life. Females to male ratio is whooping 2 to 5 to 1. The severe complicated infantile hemangioma in female to male ratio is 7 to 9 is to 1, and most cases are sporadic. The risk factor include breech presentation, firstborn female child, low birth weight, less than 2500, weighing less than 1000 milligrams. The incidence is even more, and premature infants. So the ideal patient of hemangioma in most of the cases you will see will be a preterm female firstborn child. That is what has been seen in most of our patients. Of course, there are others who might suffer for it, but this is a characteristic history that we see when we see a patient of hemangioma. Multiple gestational pregnancy, use of in vitro fertilization, advanced maternal age, placenta previa, and amniocentesis. They are the other risk factors that might lead to hemangioma. Talking about the pathogenesis of IH, it is unclear, but various theories are there. And the first one being the uncontrolled clonal expression of endothelial cells theory, which says that dysregulation of both angiogenesis and vasculogenesis plays a critical role. Missense mutations found in genes encoding VEGFR2 and tumor endothelial marker 8 leading to upregulation of VEGFR2 leading to vasculogenesis. Then there is placental hypothesis, which says that according to this theory, hemangioma cells are either of placental origin, that is why embolization or invading angioblast undergoing differentiation towards a placental microvascular phenotype. Because GLUT1, Mizorin, and Lewis Y antigens are expressed in IH cells. The concept of hypoxia is something else that goes in infantile hemangiomas. And there you see that hypoxia upregulates a nuclear transcription factor, hypoxia inducible factor synthesis, which plays an essential role in the maintenance of oxygen hemostasis. HIF1A regulates angiogenetic factors during IH progression, such as VEGF, matrix metalloprotein 9, and stromal cell, uh, and thus the hypoxic placental changes manifested as prematurity, low birth weight are associated with increased incidence of IA. So, what are the clinical features when you see? They usually appear during the first few weeks of life or may present at the time of birth as precursor lesions. The most common site is head and neck, that's up to 60%. Involvement is seen in 25% of the patients, and extremities are very less as 15% of the patient. Midline and ocular axis is common in face, and 80% of the cases will have a single lesion. So, what is the course of infantile hemangioma? They undergo a proliferative phase followed by a stabilization and then gradual involution, usually evident within first week of life or precursors present at birth. Most of the time, when you see a precursor lesion, you will just find a erythematous lesion, a macular lesion in initially, which proliferates rapidly and reach 80% of final size by 3 months of age, and ongoing slower growth ends by 9 months to 1 year. Involution is complete at median age of 3 years. So here you can see the proliferative phase where the lesion is growing. It is not only macular, it is raised, it is fiery red, and it is glistening, glowing lesion. While in the plateau phase, you see it has become as a macular lesion. There is hardly any shine on the lesion. It has come down to the skin surface, and in the regressive phase, you see even the erythema weans off. So the precursor lesion is a macula, as I said, it's hyperemia, an erythematous or telangiectatic patch with or without a pale halo, a closely packed cluster of bright red papules or a blue tinge bruise-like area is seen in most of these patients. The earliest signs of involution will be the color change from bright red to dull purple or flattening of the surface, gradually gray or milky white color, first centrally, then peripheral, and as involution progresses, breaks into smaller islands before clearing totally. So the clinical subtypes involve the superficial, deep, mixed, that is both superficial and deep. Then you have the reticular, abortive, minimal growth, and others. The morphological subtype includes focal, multifocal, segmental, and intermediate. So here you can see situated in the superficial uh, area, the most common type, that's 50 to 60% of such patients are seen here. Bright red, non-pulsatile, non-tender lesions, as you can see. And finally, lobulated surface. Deep hemangiomas are deep down in dermis and subcutaneous tissue. 15% of IH are the deep hemangiomas. Few weeks to months after birth, soft, ill-defined flesh color to masses beneath the normal skin. They are also non-pulsatile and non-tender. They are compressible to the half of their size, often becomes larger and darker when the child screams or cries. While the mixed type hemangioma you see contain components of both superficial and deep and comprise of 25 to 35%. Focal hemangiomas, that's the most common people must be seeing, it's constrained to one defined cutaneous region. Segmental hemangiomas demonstrate a geographical distribution over a specific cutaneous region, more likely to be associated with complications and anomalies, require more aggressive therapy, and overall poor outcome is seen in such patients, because even if the lesions clear, you are left with tissue mass, even if it is of skin color, there is some tissue that is not as good as the normal skin. There is scarring also at times, and the patient feels that the lesions still exist even in later ages also. So here you can see how the frontotemporal, maxillary prominence, submandibular prominence, the segmental hemangioma patterns are based upon these perspective of image analysis of hemangioma. Multifocal hemangiomas, you can see there'll be many lesions and at times you will confuse it with other conditions. At times people feel that maybe some sort of syphilis, rubella, etc. Are there, but no multifocal IH are numerous discrete local lesions present at more than one anatomical site. Screening, that's abdominal USG for hepatic hemangiomas, is recommended for infants presenting with more than 5 cutaneous IH. The complications include recurrent bleeding, ulceration, heart failure, visual impairment, airway obstruction, auditory canal obstruction, disfigurement, interference with feeding. 10 to 25% of IH, as you can see, most common complication IH on the lip, in the anogenital region or other skin folds, especially neck, have the greatest tendency to ulcerate. More commonly with large mixed segmental hemangiomas, median age for ulceration is 4 months. Astigmatism by compressing of the globe or deforming the cornea can be seen when the lesion involves the eye. Light deprivation, amblyopia, and strabismus by obstructing the visual axis or by invading the orbital musculature can be there. Proptosis, exposure keratitis, ptosis, and lacrimal duct obstruction. All infants with periocular hemangiomas should be evaluated by an ophthalmologist at baseline and closely thereafter to see that there is no untoward side effect taking place in the eye. Talking about the disfigurement, as I told you, then when the lesions are large, they don't come back to the normal size. So deep and mixed hemangiomas can distort the underlying cartilage. Hemangiomas located on the nasal tip are particularly challenging. The resultant cyanonose deformity may require reconstructive surgery at later dates also. When we talk about airway obstruction, airway hemangiomas are typically subglottic or circumferential. Noisy breathing or biphasic stridor cyanosis or cough might be there. Lower facial or beard hemangiomas often serve as markers of laryngeal hemangiomas and should be referred to a ENT for evaluation. So, proliferating hemangioma tissue contain increased levels of type 3 iodothyronin dinase, an enzyme that deactivates thyroid hormone. So, consumptive hypothyroidism is there lead to hypothyroidism in infants with large volume of proliferative phase lesions. It resolves as the tumor regresses. Evaluation of thyroid function test is recommended in hepatic hemangiomatosis, hemangiomas in parotid area, large segmental hemangiomas that we know call as the face syndrome. So the location of the hemangioma and associated involvement. A clinical pediatrician or a dermatologist should also look for other things that might go wrong if the patient comes to you with a hemangioma. If there are large facial hemangiomas, then structural vascular anomalies of CNS faces syndrome might be associated. If it's of lower facial or beard, then as I told you, laryngeal hemangiomatosis, segmental of upper face, small IH in beard area, airway hemangiomas might be there. In the midline lumbosacral area, occult spinal dysraphism might be there. Large hemangioma of lower body, lumbar syndrome might be there. Multifocal lesions of more than 5 in number, hepatic involvement should be ruled out. And parotid area or hepatic hemangioma, consumptive hypothyroidism should also be looked and should be investigated. So, talking about the faces syndrome, a posterior fossa and other obstructional brain malformations, H for hemangioma, A for arterial anomalies of cervical or cerebral vessels, C for cardiac defect causation of aorta, eye abnormalities, and sternal defects of supraumbilical raphe. A large segmental facial hemangioma is the hallmark. So whenever you see a very large hemangioma in the area involving the face, you should always investigate for faces. So here we can see we just see the hemangioma on the face, but where other sites where it might be there that's the can lead to eye abnormalities, segmental infantile hemangiomas, most of common which are on the face, sternal defects, supraumbilical raphe, and posterior fossa and other brain malformations, example the Dandy-Walker malformation and cerebellar hypoplasia and cardiac defects or coarctation of aorta can also be seen. So 90% have more than one extracutaneous manifestations. When you talk about a major criteria and minor criteria, cerebrovascular anomalies are the most common extracutaneous manifestations in as many as 91% of the patient, followed by 67% who will be having a CVS or and structural brain abnormalities in more than 50% of the patients. The most common CVS abnormalities are the coarctation of aorta and aberrant subclavian artery. So when you talk about the definitive phase, you have a major criteria where you can see in the head, and plus one major criteria or two minor criteria which are depicted here. I know it is a small font, but if you can make out the major criteria, the arterial involvements, the anomaly of major cerebral or cervical arteries, dysplasia of the large cerebral arteries. In the structural brain, you have the posterior fossa brain abnormalities, cardiovascular, as we talked about, aortic arc anomalies, like the coarctation of aorta, dysplasias, and in ocular, you have the aneurysm, the aberrant origin of the subclavian artery with or without a vascular ring, posterior segment abnormality, persistent fetal vasculature, and when you talk about the ventral and the midline, there might be sternal defects, sternal pit, sternal cleft, while the minor criteria will involve the aneurysm of any of the cerebral arteries, midline brain anomalies, and systemic venous artery arc, arterial segment, coloboma, cataracts, etc. So this was all about faces. When you come to a lumbar syndrome, large hemangiomas on lower body have been associated with severe conditions. Here you can see the myelopathy, which is a tethered spinal cord, lower body segmental infantile hemangioma, a lipoma, other cutaneous anomalies. That's a skin tag might be seen in this area. Bony deformities, that is sacral anomaly, hip dysplasia, renal anomalies of a hypoplastic or single or pelvic kidney, urogenital abnormalities of the bladder, uterus, or genitalia, and anorectal anomalies, imperforate anus fistula might be there. So the various syndromes that the pelvis, where you'll find the perineal hemangioma, external genital malformations, lipomyelingeal, vesiculorenal abnormalities, imperforate anus, skin tag, etc., lumbar and sacral, as we have already discussed. So all these can be associated when you have a large hemangioma in the lumbar area. So it might be with or without cutaneous infantile hemangiomas. Many HIH or symptomatic ones present with hepatomegaly, high output cardiac failure in the first 3 months of life, may be focal or multifocal. Focal HH may be evident on antenatal ultrasound, are usually GLUT1 negative, occur without cutaneous lesions. Multifocal HH are usually associated with multiple small cutaneous infantile hemangiomas. Diffuse HH is a term that has been used to describe massive involvement in liver, often with symptomatic arteriovenous shunting with high output cardiac failure. So, talking about the congenital hemangioma, there are benign vascular tumors that proliferate into utero and do not show any further proliferation postnatally. It is the prenatal ultrasound in second and third trimester. You can make out that the child is suffering from such condition. Talking about the rapidly involuntary congenital hemangioma on the leg of a 6-week-old male showing as a peripheral pallor, while a non-involuting congenital hemangioma in an 11-year-old child, you can see it is still left with a bluish, purplish stains and peri-lesional hollow. So when we talk about infantile hemangioma, rapidly involuting congenital hemangioma and non-involuting congenital hemangioma, the first one that we are talking about, the topic for the day, is usually absent or is a precursor lesion is there at the birth, while the rich are fully developed. while the niche are fully developed, and rapidly postnatal proliferation is seen, intrauterine proliferation is seen in rich, and intrauterine proliferation, then proportional postnatal growth is also seen. In IH are more commonly in girls, whereas there is equal prevalence of rich, and slightly more is seen in niche in boys compared to infantile hemangioma, which are most commonly seen in females. Talking about the infantile hemangiomas and vascular malformation, many a times when patient comes to you and the lesions are large, and at times you are confused whether you are tackling an infantile hemangioma or a vascular malformation. uh, IH will appear in first week of life, and malformations are usually present at birth, something like a port wine stain or salmon patch. Infantile hemangiomas which proliferate rapidly. Vascular malformation will be proportionate growth with age. IH will involute over years. Vascular malformation will not. IH will be more commonly in girls where there is no bias in vascular malformations. IH will be non-pulsatile, and vascular malformation will be associated with thrill, bruit, pulsation, plus in vitro venous malformation, and will be warm to touch. So Doppler and vascular imaging might be required to differentiate between hemangiomas and various other vascular malformation. In your clinical practice, when you see such patient, this is something that you should look for in patients and history. And most of the time, when you people are there in the labor room, and if you see a vascular malformation, and if you have seen there when the child is born, you are more usually tackling with the vascular malformation. And infantile hemangiomas are only once the family brings the child to you in first week or second week of life, that doc, this was not there on birth, but we are seeing that such a lesion is slowly developing. You are most of the times dealing with the infantile hemangioma. So investigation, when you talk about what all you should get it done, is a USG Doppler, well-defined soft tissue mass, heterogeneous texture, fast flow pattern will be there. MRI brain or neck should be done, especially when you have large lesions. MRI with gadolinium enhancement is regarded as the best single technique to evaluate vascular anomalies. MRI spine, a plaque hemangioma in lumbosacral area should be done in such cases. And abdominal ultrasound, when you see more than 10 cutaneous hemangiomas, perianal or perineal hemangiomas. Thyroid function test in liver hemangiomas, parotid hemangiomas, face syndrome. ECG to rule out associated structural and functional cardiac anomalies in cases of suspected face syndrome. ENT referrals, suspected airway hemangioma, and ophthalmology referral in periocular hemangioma should always be done. Now, after we have discussed these things, let's move on to the management. Majority of cases undergo spontaneous involution, so it is only hand holding that you need to do. Avoid therapeutic intervention. Goal of management should be preventing or reversing life or function threatening complication, treating ulcerations, preventing permanent disfigurement, minimizing psychosocial distress to patients and their families, and avoiding overly aggressive, potentially scarring procedures for lesions that have a strong probability of involuting without significant residence. So, active non-intervention is the most appropriate approach for majority of small hemangiomas. That is visits at regular intervals to make sure that nothing untoward is taking place. Takes I can see participant raising hands. Do you want me to answer questions in between the presentation? The
So
moderator.
I'll be asking questions in between, and some questions we'll take at the end, which can be
Okay.
answered.
So I'll be waiting for you only because there are people who are raising their hands now.
Yes, sir. I'll take up their queries.
Okay. So photographic documentation is something very important. Whenever a patient comes to us, we tell the parents that make sure you take a photograph in the same light, in the same background. Maybe at home you can use a white bed sheet, and in the same light exposure at the same time with the same camera at the same distance. Because many times patient will come to you first time they have clicked the photograph in the dark, next time out in sun, and there are various sort of backgrounds that are there. So it becomes difficult for you also to comment whether the lesion is progressing or it is healing. So make sure you tell these parents to take a photograph every Sunday morning, so that when they come to you after 2 3 weeks, you also know that what's happening with the lesions. So if you see ulceration or severe hemorrhage, it's at an anatomical location where there is interference with important structures such as eyelids. Aesthetic handicap might take place, or significantly, especially if it is on nose, lip, or ear deformity, or scarring might occur. So these are the indications of intervention. Life function threatening hemangiomas that are impairing the vision, hearing, airway, feeding problems, or heart failure. Psychosocial sequelae once the child enters the school. So it becomes very difficult when you see when there was no propranolol and the patient was just left out, even if they were having big hemangiomas, large hemangiomas, and you see the scarring tissue, the loose flabby tissue that you see in such patient, the older age group, it becomes very distressful not only for them, for their families, but they are not able to move out in society, and because people keep asking what has happened. So to avoid permanent disfigurement, it is always important that you should do active intervention, and you should give some sort of topical or systemic. So the therapeutic interventions in infantile hemangiomas are the beta blockers that are the mainstay nowadays. For smaller lesions, timolol 0.5% solution gel forming or 1% propranolol topical ointment you can use. Topical intralesional steroid, they have been time tested before beta blocker. They were only the mainstay of the treatment. Topical imiquimod 5% cream has been tried, and then you have the laser, that is the pulse dye laser. Talking about the systemic treatment, when the lesions are large and you require something more, or the topicals are not acting, you give oral beta blockers, propranolol and atenolol, oral steroids. Nowadays, oral itraconazole is also there that can be used and has been used. Rapamycin, vincristine, cyclophosphamide are the other agents that can be used. Other modalities include sclerotherapy, surgery, embolization, and cryotherapy. So the most common drug that is used in a small lesion is the timolol maleate. It's a non-selective beta-adrenergic receptor inhibitor. 0.5% solution is available as eye drops, and you have to just ask the mother to apply one drop on the lesion and massage it for around 15 seconds twice a day. One drop of this drug contains 0.25 milligram of timolol, and twice a day application is what is required. Effective and safe for small, less than 2.5 centimeter of lesions, which are superficial, non-ulcerating cutaneous IH in the age group of 5 to 24 weeks. Significant improvement is seen in around 12 to 16 weeks. So if you start seeing improvement in say first couple of months, and the lesion is not increasing in when you have started applying in the first month itself, you are on the right track, and you can continue with the patient on timolol maleate. Once you have given timolol maleate, the redness, the glistening glow that you see on the lesion start to reduce, and sooner or later the lesion will become flat, and then the erythema will vanish. Talking about the interlesional corticosteroid, triamcinolone should not be exceeded in 3 to 5 milligram per kg per session. Can be used for small focal lesions. Concentration of 5 to 40 milligram have also been used. But with nowadays timolol maleate available, it's hardly that we use intralesional corticosteroid. Avoid in periorbital hemangiomas, risk of retinal and ophthalmic artery occlusion leading to permanent visual loss is there. Also, local atrophy and necrosis can be there. So it should be a call should be taken that whether you still need to give intralesional corticosteroid when you have topicals and at times oral beta blockers available with you. The gold standard drug that is used nowadays for larger hemangiomas is the oral propranolol. It is non-selective beta 1 beta 2 antagonist. It's the first FDA approved treatment for proliferating IH that requires systemic therapy. It was approved in 2014. effective and proliferative phase, that's the maximum benefit, or involuntary and ulcerative lesions or lesions involving vital structures like airway or liver also has been treated. The early effect is a visible change in color and considerable softening of the lesions, which occurs in as less as 1 to 3 days after initiation. I have seen as soon as we start giving oral propranolol and the lesions are large, they start becoming dull, gray. And if you could feel, if you have admitted the patient with you, there is some sort of a burning smell is there in the room also when you start oral propranolol, that I have seen in my patients. So that's first thing, that you can smell also that the drug is acting. uh, Sooner or later, in a couple of weeks, you will see that the lesion decreases, the redness vanishes, the skin color starts to come, and day by day you will see the improvement in the lesion. The early effects, it is due to beta 2 inhibitory effects, that it decreases the release of vasodilator transmitters such as nitric oxide, and hence leads to vasoconstriction of the feeding capillaries. That's the reason why the redness vanishes. Intermediate effects is it did down regulates both VEGF and beta FGF, resulting in inhibition of pro-angiogenic cascade and angiogenesis. Long-term effect is due to the apoptosis, resulting in regression of hemangiomas. Contraindications of treatment with oral propranolol is if the BP is less than 50/30. So most of the time when we start patients and we start beta propranolol slowly, we start with zero point 0.5 milligram per kg body weight and go slowly to 2 milligram per kg body weight. And we ask the parents to make sure that we take the help of our pediatrician friends, that to monitor the blood pressure, so that if some bradycardia is taking place or if the BP is going down, we have to see that whether we can give the drug or not. In case of second or third degree heart block, hypoglycemic episodes might be there, so we ask the mother for frequent feeds. Because the taste of propranolol is very bad, it is very sour, so we ask the mother to either mix it with honey or with sugar with the drug. So that also helps. But hypoglycemia, we ask the parents to make sure that the child, the frequent feeds are there. Hypersensitivity to propranolol might be there. Frequent wheezing, bronchospasm might be there. For children with suspected faces syndrome, it is essential to improve the cerebral blood vessel, as in some situation propranolol may be contraindicated because of the risk of cerebral ischemia. So full clinical history and examination, including heart rate, BP, and oxygen saturation, is required. A pre-treatment ECG is required if the heart rate is below normal, if arrhythmias is detected on cardiac examination, if there is a family history of arrhythmias or maternal connective tissue disease is there. Pre-treatment ECG and echo required if history and signs of cardiovascular disease is there. Talking about the dose, a dose of 1 to 3 milligram per kg per day with 2 milligram per kg per day as median dose is there. As I told you that we start with a lower dose and slowly increase over a couple of weeks. It is recommended to start from low dose, given as 3 divided doses with minimum of 6 hours in between them. When the child takes care that there is no untoward side effect that we are seeing, most of the time nowadays we give 2 divided doses. Adjust the dose according to the weight gain with age. That is very important, because when there are large lesions and the child is growing, the it's not that if you have calculated the dose on 2 milligram per kg for a 10 kg old child and the child is growing, because this needs to be given for as much as 6 to 9 months at times, when you are dealing with large areas. So when the child becomes 12 kgs, you have to increase the dose also. Monitor BP and heart rate immediately before first dose and every 30 minutes for 2 hours. Give for approximately 6 to 12 months, taper over 2 to 4 weeks to avoid rebound or hyperandrogenic withdrawal response. Because at times, though very rare, but we have seen that there is rebound phenomena also when we stop the drug At times, the lesion might come back also. So, administer propranolol during daytime hours only, administer propranolol shortly after each feed. Frequent feeds are advisable. If the child refuses feeds, skip the propranolol dose, give the exact dose of propranolol prescribed. This is for the parents. If your child spits out the dose or there is uncertainty of how much medicine went in, just wait until the next dose. So all these things we give to the parents to make sure that nothing untoward take place. The parents make sure that they are giving the right dose, and if something is not right, they should visit the pediatrician. And for every rise in the dose, I make sure that my patients go to my pediatrician friend, that when I increase the dose from zero point 0.5 to 1, I'll again ask them that, okay, go to his clinic, wait there for 3 to 4 hours, get your child's blood pressure and heart rate monitored, and if everything is fine, you can come back. Every time I increase the dose for the first 2-3 times, that is every week I increase the dose, I make sure that the parents take the child for a couple of hours, if not more, to make sure that nothing untoward is taking place with the heart rate and the blood pressure. So you can see the propranolol treatment, a 3-week old infant with segmental proliferation hemangioma. Such fast results are seen. The side effect, as we told you, is hypoglycemia, hypotension, bradycardia, bronchospasm, cold extremities, sleep disturbances, GI disturbances like diarrhea, stomach pain, which is very rare, and somnolence more than first few weeks, irritation and behavioral changes might be seen. The ideal time to stop is when the complete regression, that is 6 to 12 months, occurs. More IH partially regress than completely regress after propranolol treatment. In cases of partial regression, stop when patients are more than 1 year of age. Follow up monthly until signs of involution, and then 3 monthly until cessation of treatment. Long-term treatment reduces chances of relapse. Other drugs are available like etinolol, acebutol, and nadolol. It is there in the literature, but we don't use it. Systemic corticosteroids were once the mainstay of the treatment, but corticosteroid suppresses angiogenesis by inhibiting, and we have seen that the dose was 2 to 3 milligram per kg per day. Steroids are most effective in early proliferative phase, but now they have been replaced by oral beta blockers, so we hardly give systemic steroids. Oral itraconazole is the new drug on the block, the new baby on the block. The mechanism of action is itraconazole retains the endothelium in G1 phase of cell cycle and restrains the angiogenesis through VEDGF signal pathway. It increases, suppresses the activation of PDGF and downstream effective pathway, which are important for cellular growth and survival of IH. The dose is 5 milligram per kg per day for 2 to 9 weeks, has shown significant efficacy. You have oral itraconazole syrup available. Stand a promising new therapeutic approach for IH, does not require inpatient administration, thus better compliance, as low price, minimal side effects. So it has been tried. There is a lot of literature at times, because we are more comfortable with propranolol, but we have seen few cases where the patient has not shown results with propranolol, and we shifted the patient of itraconazole, and the drug showed great results. Chemotherapy, vincristine, is often used for the treatment of Kasabek-Barres phenomena, and it is when tumors are associated. This is the second line of treatment for aggressive, complicated IH. The usual dose is 0.05 milligram per kg. Cyclophosphamide, rapamycin, recombinant interferons have also been tried. Laser, the 585 flash lamp pulse dye laser is something for treatment of ulceration, hastening resolution of erythema in IH, best for superficial lesions, pigmentary alterations, ulceration, scarring can occur with the laser. Multiple sessions are required. CO2 laser is to minimize the blood loss of for problematic hemangiomas, and ND-ACT laser for greater efficacy of deeper lesions, but higher chances of scarring are there. So when you are dealing with the large areas, you are giving the oral medication. At times you are left with some tissue, loose tissue. pulse dye laser is something that can give great results in such lesions also. And surgical excisions are for localized ulcerated lesions, for involuted or partially involuted lesions to remove the fibrofatty tissue. Redundant skin and lesion where significant psychosocial effects might be minimized by early surgery. Decision regarding surgery can often be made up to 3 to 5 years of involution is not complete, and lesions over nasal tip and lip often require surgery. So, services of a good plastic surgeon are required. Embolization is generally reserved for life-threatening hemangiomas that have not responded to medical management. Early embolization is recommended for focal lesions with a mean of a quickly controlling the heart failure, can be combined with other modalities and prior to surgical resection surgeries. Compression, both intermittent pneumatic and continuous compression, have been used to treat symptomatic hemangiomas. The disadvantages include possible ulceration, discomfort from the pressure. Radiation therapy is rarely used as a last resort, and contact cryosurgery can cause scarring and pigmentary alteration. So these are things there in the literature, have been also used by many clinicians when nothing else works. But the golden drug for you nowadays is oral and topical beta blockers, that is timolol maleate and propranolol. Itraconazole is fastly catching up as the drug of choice because a lot many things needs to be taken care with propranolol. So itraconazole will be something that will be used more commonly in future for your patients. And of course, when you are dealing with large areas, make sure that you investigate the patient very well, that you are not skipping or ignoring any other problem that is there inside the body. So make sure that you take help from your dermatologist friend, from your radiologist friend, and investigate the patient thoroughly before taking them for a treatment, and monitor the patient very well. You are the masters in monitoring when you have to monitor the heart rate, the blood pressure, and other things. The first contact for the patient is the pediatrician. So the family needs your support. You have to counsel the patient that, okay, the things are working, they are going in the right direction. And sooner or later, the lesion will completely heal. Maybe a mark might be left. And for that, also, there are various things that can be taken care at a later date. Thank you.
Thank you, Dr. Rohit sir, for a wonderful presentation and exhaustive details. So there are a few questions. What is the minimum age for use of itraconazole?
Itraconazole, as I told you, because we are more comfortable with propranolol, I have used in 3, 4 of my patients only when I saw that the propranolol is not working, or there was a patient who was complaining of uh, uh, hypoglycemia and low heart rate. So my pediatrician friend told me कि भाई इसको तो नहीं देना. So this was in 6 to 7 months of age patients. I have given itraconazole, and it worked. And
Okay.
in dermatology fraternity, there are many others who are giving itraconazole because it is easy to monitor. We have, if you know that the dermatophyte, the fungal epidemic is running nowadays in our country. People are suffering, and itraconazole is prescribed left, right, and center. It doesn't have any side effects. So even in children, we have been giving it. So 6 months is something that I have given itraconazole also, 6 months of age.
Please stop sharing the screen so that we can have. So can we combine timolol and itraconazole for some patients if required?
Yes, because see, even our propranolol patient, we prescribe timolol maleate. Timolol maleate, to we prescribe on day one only. Even when we send the patient for investigations for lesions, we don't start propranolol. I'll send the patient for an MRI or other investigations, and by the time they come with MRI, because most of the patient will take some time, that why you have suggested MRI for a child. The child is so young, they will go to their pediatrician, they will counsel, they'll talk. So that 1 week is taken for most of our patients to get the MRI done. So timolol we give then and there, and as soon as they come, we start with the oral medication. So itraconazole and timolol can also be combined.
Shouldn't we have a wait and watch policy, because most of these lesions will ultimately go away?
Yes, I told you that if you are dealing with a small lesion, wait and watch is fine. It is only most of these patients will come to me when my pediatrician friends have are seeing that okay, the lesion is increasing, and most of the time the timolol maleate has also been prescribed by them. It is then that we see lesions. कि भाई see whether we are dealing with hemangioma or not, and then I send them back that okay, it is hemangioma only. We have to start propranolol. This is the drug. This will be the dose, and you, because your first point of contact is your pediatrician, increase the dose and show me once in a month or 2 months time, so that everything is going fine. When ulceration is there, then only the combined team of dermatologist and the pediatrician comes into picture most of the time, that we have to treat the ulceration also. At times we give timolol maleate as well as a topical combination of steroid and an antibiotic also to take care of crusting, of ulceration, etc.
Because the natural history is such that it will increase for a few months and then regress.
Yes, but if the lesion is going beyond, say, 3 to 4 centimeter, at times it is a prudent idea nowadays, because a 3 to 4 centimeter lesion, at times if it will involute itself also, it will leave a mark. So it is always better to restrict the lesion and start at least timolol maleate.
Is the timolol gel available in the market?
Eye drop is available very easily. So a one eye drop will last more than 2 months for your patient if you are dealing with a small lesion. So just one drop to be applied and massage for around 15 to 20 seconds twice a day.
Dr. Anukriti, any more questions that you want to ask, sir?
Sir, one attendee wants to know what is the line of management for a liver hemangioma.
See, for that we usually refer the patient back to you and to a pediatric gastroenterologist also, because it requires, as I told you, at times they need to embolize, and what needs to be seen, what sort of a lesion is there, and what all compression it is causing needs to be taken care by a pediatric gastroenterologist only. And if there are hemangiomas, and if we are giving propranolol, that needs a clearance from the gastroenterologist also.
Uh, any
Thank
more
you, sir.
questions?
No, sir, no more questions.
Most of these are almost same question. Any role of topical steroids?
When you are dealing with a small hemangioma, at times we give timolol maleate as well as a topical mild steroid also to take care of the crusting. So, as I pointed out, a topical combination of topical steroid as well as an antibiotic cream in case of crusting ulceration can be prescribed. But there should be a gap of around 1 hour between you applying the timolol maleate as well and this preparation. In case of ulceration, don't give timolol maleate, just apply the topical steroid and antibiotic combination, and you can give oral propranolol.
One more thing, I'll suggest that if any patient one thinks that needs itraconazole, should be done in consultation with dermatologist.
Pardon?
If a pediatrician thinks that itraconazole will be required, it should be done in consultation with a dermatologist only.
See, because it's a new drug, otherwise it is safe. And the only thing that you should take care is that all these azoles, they affect the liver. So just get a liver function test done. We get it repeated if we are giving our patients itraconazole, even in adults. If you are giving it beyond 4 6 weeks, we get a liver function test done.
Sir, if you'd like to share any PDF of that charts you had shown, you can send it to me and I'll share with the delegates.
Sure.
And if there are any more questions, we'll get back to you later.
Sure.
Thank you so much, sir, for a wonderful presentation. And I thank Dr. Anukriti for answering most of the questions. And we are thankful to the delegates for joining on a Sunday morning. It's
In
getting
huge
quite...
numbers. Like early morning, I was astonished to see there were more than 400.
Yes, sir. Thank you so much.
You're
Mr.
welcome.
Sushil, please close the session. Thank you.
Bye-bye.